Okay, so we're going to go over chapter 32, which is the OB and GYN emergencies. There's a lot of information to take in. We're going to talk about the anatomy, the physiology. We're going to talk about the physiologic changes in pregnancy. We're going to talk about labor and delivery, patient assessment before and after childbirth, actual normal childbirth, the neonate, care after delivery, some childbirth complications, and some gynecological emergencies as well. So first, let's do a quick little anatomy review. So this is a cross-section of the internal female anatomy. And if you can see right here, the external is called the vulva. And then you've got the labia, which is basically they call it the vestibule to the entrance to the vagina. Now the vagina right here, if you can see my mouse, is the entrance to the uterus, which is a very muscular organ right here. Now the uterus itself is normally about the size of like your fist or so, and it's normally small and compact right there. During childbirth, this uterus expands vastly and grows to accommodate this fetus in utero. Now right here, at the end of the vagina and the entrance to the uterus, you've got the cervix. You also have the bladder, which is right here, which sits kind of just under the uterus. You've got the clitoris, which is a bundle of nerves here. This is the colon right here, and you can't see it super well. It'll be better in the next picture, but right here you've got your fallopian tube and then your ovaries. So this is from looking at just the female anatomy in and of itself from a front-facing view. So here you've got the birth canal or the vagina. You've got the cervix, which is the opening, the muscular opening to the uterus, which is right here. All right, the fundus is just the top of the uterus. That's all that is. And then here you've got your fallopian tube, and then it opens up over here by the ovary, which is producing and releasing the eggs. Now, women are born with every egg they'll ever have. So if you have a 33-year-old woman, her eggs are 33 years old. This is in contrast to men who will produce sperm typically their entire life. Now the quality of sperm may diminish as they age, but typically they will continue to produce new fresh sperm their entire life. So this is why when you have an older female, usually after about age 35, 36 or so, the risk of birth defects and complications go up because the age of their eggs. Now, with the menstrual cycle on average, textbook average, is about 28 days. So all the numbers as far as like what happens on what day is based off of that average of 28 days. But it's very important to note that the cycle itself can range anywhere from 21, 24 days up to 35. So 3 weeks to over a month. So it really just depends on each individual. This menstrual cycle, when it begins, is called menarche, and that's around puberty, and that's usually around 10 to 14, somewhere right around that neighborhood. And then menopause is the cessation of the menstrual cycle, and that usually starts in the 40s, and it'll kind of start presenting with irregular menstrual cycles, that kind of stuff, and then it will finally end up with cessation of the menstrual cycle altogether, and that's going to represent the end of childbearing abilities. Right. So this whole cycle is stimulated and controlled by hormones, by chemicals, by estrogen and progesterone. And each month, the first day is considered the day when they start bleeding, and then about 14 days after that is when most people will have ovulation, and that is where the ovary is going to, the corpus callosum that holds the egg is going to rupture, and then the ovum is released out, and then if there are sperm present, then you typically will have fertilization. And that fertilization normally will occur in the fallopian tube, and then the peristalsis will just kind of move that egg down into the uterine wall. Now, in preparation for the for implantation, the uterine wall during the menstrual cycle every month will thicken. The endometrium, the inner lining, will actually thicken and prepare for a fertilized egg to implant. If that fertilized egg does not implant, then the uterine walls will slough off and will be expelled, and that's what basically starts the menstrual cycle over again. We recognize that as a period or a menstrual cycle, the bleeding portion of it. Right. Now, fertilization in and of itself, typically, like I said, typically happens in the fallopian tubes, but it can happen anywhere. It just depends. Sperm can live up to about 5 days, typically inside the uterus or the fallopian tubes before they die. But the sperm reaches the egg, the ovum, and then it becomes a blastocyte, and then that blastocyte turns into an embryo. I think it's 4 to 5 days after that or so. And that embryo will implant into the uterus. At this point, if it implants, then the chemicals released from the egg and the ovaries will actually sustain the embryo until the placenta can begin to develop, and then now we are in the actual fetal stage. All right, so this embryonic stage is about the first 8 weeks, about 2 months, and this is usually initially before people know they're pregnant, and then shortly thereafter, the first little bit. All right. After this first 8 weeks, it's no longer considered to be an embryo. It's considered to be a fetus, which it will be considered a fetus until about the next 32 weeks, basically the entire rest of the pregnancy, which is average or normally about 40 weeks. Anything before 37 weeks, just FYI, is considered to be premature. Now, let's talk about some physiological changes in pregnancy. There's a bunch of them. All right. So the placenta, which if you see right here at the, right here by the baby's foot, you got this little thing that seems to be kind of coming off of the uterine wall. That is the placenta. Fun fact, it's the only temporary organ in the human body. But it develops after the ovum is fertilized and implants on the uterine wall. And it is what actually provides the oxygen and nourishment to the fetus and gets rid of the CO2 and waste products. And what's really cool is it does it in a way that the blood of the fetus and the blood of the mother do not mix, which is super important because if their blood types are different, then the mother's body would actually potentially attack and kill the fetus if the blood mixed up, or it could cause a really bad problem for the mother. So it's really cool how it all works. Now the umbilical cord, which gives us what we know as our belly button, is what attaches the fetus to the placenta, and it has it has one vein and 2 arteries. Now, in this case, much like the pulmonary arteries and veins, the vein actually carries oxygenated blood and nutrients to the fetus, and the arteries carry deoxygenated blood and waste products back to the placenta, to the mother, to get rid of. You also have the amniotic sac, which is this membrane that surrounds the embryo and the fetus, and it is filled with fluid, anywhere from 500 to 1,000 milliliters, just depending on the size of the fetus and the needs. And the fetus is floating there, and it's kind of insulated and protecting it, kind of like a sensory deprivation chamber, but they can hear stuff. It's pretty cool. But it cushions them and protects them and keeps them safe. Now, with this reproductive system, all right, so the uterus, normally we saw that picture earlier, it's small, it's, sits right there on top of the bladder, and it's pretty well protected by the pelvic girdle. If you see in this picture here, it comes way up here, so it's no longer down here below all the bones and stuff protected. It's very vascular, and it has almost 1/6 of the total blood volume of the mother. All right, which their blood volume increases by 45% during pregnancy, so they get almost half extra blood volume. So with this, it's poking out a lot further. It's not as well protected. It's very vascular, so it makes it much more prone to injury or problems there. All right, the respiratory system, oxygen demand goes up about 20% because they're breathing for another person, right? Their resistance in their respiratory tract decreases, their tidal volume goes up by 40%. If you think about why would you think their tidal volume will go up? I mean, they do have more oxygen demand, right? But 40%, almost half, seems like a lot. Well, what happens is as this uterus grows and this baby grows, it will actually start to displace, because that's a lot of stuff right there, right? It's displacing the organs and everything else that's normally just chilling here in the abdomen, and it's pushing it up and out. And so right up above here, you actually have your diaphragm, right? And so it's pushing all these things out, and it will slightly displace this diaphragm, which will then mean that there's less room right here for the lungs to actually expand. So they're a little bit shallower respiration, so they take in more oxygen a little bit more frequently to try to compensate for that. Now, the cardiovascular system, we said the cardiac output, how much blood's coming out of the heart, actually increases. All right, we're pumping more blood faster because we're pumping for 2 people, right? The blood volume, like we said, goes up almost by half. And the maternal heart rate goes up about 10 to 15 beats per minute normally because they're having to adjust and compensate for that extra blood volume that they are sending around. Now, during the first 2 trimesters, the blood pressure typically will go down just a little bit. All right. You know, it goes down a little bit during that first thing because that blood volume is starting to increase a little bit. Now, in the last trimester, it usually comes back to about normal. There is a very serious potential complication called preeclampsia and eclampsia with pregnancy, and it becomes more significant usually in the last trimester. And one of the hallmarks of it is high blood pressure. And we'll talk about it a little bit more later on, but if you have a pregnant lady who has high blood pressure, take it very seriously. Something that we might not normally be super concerned about, 130, 140 over 80 or something like that. If they are pregnant, consider it to be a very potentially serious complication until proven otherwise. All right. They also have increased clotting factors and increased clotting risk because more volume, a little bit less perfusion usually in the extremities, so they're a little more prone to having clotting issues as well. Now, your GI tract, we talked about how the growing uterus here kind of displaces all of the intestines and all of the abdominal organs kind of out of the way. It moves them and pushes them around. So that's going to cause some problems. They're common to have nausea and vomiting, morning sickness in the first trimester, but that morning sickness apparently can happen at any time. Doesn't have to be just in the morning. That usually subsides a little bit after the first trimester. They have decreased motility because everything's kind of squished and compressed and moved out of the way. So this can cause some bloating. It can cause some constipation, especially during the later parts of the pregnancy as well. All right, for the urinary system, we've got increased blood flow to the renal system, which means increased urinate output, hopefully, if everything's working right. The bladder is displaced a little bit, and if you look right in this picture, that big old baby's sitting on that bladder, right? So that's going to increase the frequency in urination and increase the potential for any kind of urinary bladder injuries. Now, as far as the musculoskeletal system, later on in the pregnancy, you get some hormonal changes that will actually kind of loosen up these ligaments here in the pelvis. And what they're doing is these ligaments are becoming more elastic, which means it's going to make childbirth a little easier because that pelvic ring will be able to open up a little bit. But it also means that their ligaments are looser before pregnancy, which means they're more prone to injury. All right, they also have a change in the center of gravity because of this uterus. It's changed where the normal center of gravity is, so they're going to compensate, which causes lower back pain, but they're also more prone to falling or something, or having difficulty getting up, something like that, because of the change of the weight placement in the center of gravity. All right, so now let's talk about labor and delivery. So the first stage, there's 3 stages of pregnancy, okay, and the first stage starts with regular contractions and the thinning and effacement the effacement and dilation of the cervix. So effacement is the thinning of the cervix. Normally the cervix is a tight little muscle. It's about 1 inch thick and about an inch or so wide. During dilation and effacement, it opens up to about 10 centimeters, which, if you can imagine, take your hand like you're making like the hang 10 sign, like your thumb and finger, pinky out, hold it apart. That's somewhere in the neighborhood. All right, and it gets as thin as a sheet of paper. So it thins out a whole lot. So the first stage starts with these regular contractions and the starting of the dilation of the cervix, and it ends when that cervix is fully dilated. This can take several days or even a week or so. You may have Braxton Hicks contractions during this, which are kind of like practice contractions. These are irregular and they're usually not sustained, but what's happening with Braxton Hicks is this uterus is squeezing from the sides. It's not squeezing from the top, pushing down. So it's not actually progressing the movement of the fetus or anything. All right. In real labor, the uterus will contract regularly and that cervix will be dilating. All right. And then the fetus's head starts to come down. All right. When we are timing contractions, we're going to time from the start of one contraction to the beginning of the next contraction. That's how we're going to time to see how long they are and how frequently they occur. Obviously, the stronger they are, the longer they last, the more frequently they are occurring, the closer we are to actual delivery. Lightning is a term you may hear, and that means where the fetus has descended down into the birth canal. Now, the second stage of labor starts when you have full dilation of the cervix, and it ends when the baby is actually born. All right. And the third stage is going to be the delivery of the placenta, and this can last anywhere from 10 to 20 minutes. We are not going to pull on the placenta. We will let her deliver the placenta on her own. And you're not going to wait to transport for the placenta to deliver as well. Now, for your patient assessment, we'll come back around and actually talk about the actual childbirth. We're just going through the information first. So for our patient assessment, before we actually do that, we need to talk about some terminology. All right, so gravida is the number of pregnancy. That's how many times they've been pregnant. Regardless of the outcome, how many times have they been pregnant. Para is how many number of live deliveries they've had. Okay, where they actually delivered, the baby made it. Prima gravida means the first time pregnant. Prima para is the first delivery. So if you have somebody who's gravida 3, para 2, that means they had 3 pregnancies but only 2 births. So they would have, and you may see sometimes abortion or abrupto or something like that. That means that they had a pregnancy that did not produce a live birth. So this would be either due to a medically induced abortion, a miscarriage, or anything of that nature. But for whatever reason, they were pregnant and then they did not end up with a live birth afterwards. All right, we said earlier, Braxton Hicks, these irregular contractions, and lightning is the dropping of the fetus down into the birth canal. All right, so when we are assessing a woman in labor, we are going to focus on, are they about to deliver a baby? Do we have to deliver this baby? Do we have to help? All right, we cannot stop it if it's happening. All right, we are there to assist. And if you have imminent delivery, putting a quarter between their knees and holding on to the hospital will not work. When that baby's ready to come out, it's coming out. All right, so you need to be prepared to treat the mother appropriately. So we're focusing on, are they about to deliver? We're going to find out their name, their age, their expected due date. That's really important. If we're due tomorrow, there's a better chance you're about to deliver that baby. If we're due in 3 weeks, we may have some complications there. So it's real important to find out what that expected due date is, okay? We want to find out, is this their first pregnancy? You know, if this is their first pregnancy, then it may take a little bit longer. We don't know that they have what they call a proven uterus, where they've delivered a vaginal birth before, so we don't know for sure if they can or not until they have. You know, if this is their 5th pregnancy, it's probably going to go a little bit faster. So just some things to think about and see. All right, have they seen a doctor about this pregnancy? Have they had prenatal care? If they've had prenatal care, then maybe they know if there's any complications. Maybe there aren't any complications. Usually prenatal care means better outcomes for the mom and for the baby. Okay? We want to find out, when do the labor pains start? So how long? Have we been laboring for an hour? We've been laboring for 6 hours. You know, it really just depends on how frequent the contractions are and how far has this gone. We also want to find out, has their water broke? You know, do they know that their water's broke? Have they lost their mucus plug? All these things we want to find out what's going on and see, are we going to have to get ready to deliver this baby? Okay. Now, do they have the urge to push? Women with this contractions, they will feel the urge to push. And if you have the urge to push, that means they're about to deliver. That's imminent delivery sign. You also have crowning. Crowning is another imminent delivery sign. That means you can see the top of the head of the baby. So obviously it's coming out. You may have some perineal bulging around the vulva area where it looks kind of poking out a little bit. That means the baby's head's pushing everything down and it's about getting ready to deliver as well. They may feel the urge to push and interpret it as an urge to have a bowel movement. So if they have the urge to have a bowel movement, that also should be considered imminent delivery. Okay. If they have any of those things, if they feel that urge to push, if they're having crowning, and you're going to have to visualize to see if they have crowning. So you're going to have help them in a private area, remove their underwear and their pants or their bottoms, and visualize their vaginal area, their vulva, to see, are we crowning, okay? If they're not crowning and you decide to transport, cover them up, leave their pants off. All right, that way you have access if you need to stop and deliver on the side of the road if you don't make it to the hospital. Okay, if you do have any of those things, then you need to start preparing to deliver where you are. Go ahead and call for some additional assistance. If everything goes well, that's fantastic. But if something goes wrong, you cannot adequately care for a mother and a child if either one of them have a problem. So go ahead and call for some additional help to come be on the way. All right, we're going to feel for uterine contractions. If you put your hands on their abdomen, you can actually feel those uterine contractions when they start to contract. So you can kind of tell, are they from the top, are they from the side, what's going on. All right, we're going to take our vital signs. We're going to get vital signs and see how we're doing, see how mama's doing. You can normally expect heart rate, blood pressure, that kind of stuff to go up just a little bit during an actual contraction. All right, now, when we crown, we're checking for crown. We're looking to see, like right here, you see the top of the head. That means baby's on the way. Get ready quickly. Here it comes. All right. Some things that you may run into that say, hey, we might need some resuscitation, so we definitely need to get another unit on the way, okay? If they've had no neonatal care, no prenatal care, if they've had a premature delivery before, or if they've had complications from previous deliveries, then the odds of having complications later on go up a little bit, okay? If they are having a labor that is induced by trauma, all right, so if they fell or if they were in a car wreck and now they're into labor, that means there could be a problem with the baby, all right, or the problem with the mama and the body is trying to get rid of the baby to save mama. So any kind of labor that's induced by trauma should put you on high alert. If you have multiple births usually are smaller and they're usually born a little bit premature. So by just the nature of what they are, they're automatically going to qualify for a higher risk pregnancy and delivery there. All right. Some other things, history of problems during pregnancy. If they've got placenta previa, a breech presentation, or anything like that, that also means that you have a higher risk for problems. All right. If they've got a labor that was induced by a drug use, especially narcotics, cocaine, alcohol, anything like that, that's going to put that baby at a much higher risk. Right. If the water breaks and they have what's called a meconium staining is often a sign of fetal distress, and that's a bowel movement in utero, and it will actually change the color of the amniotic fluid. So that means that there's a higher chance of fetal distress as well. All right. You got somebody who's having really bad pain from contractions. When do you think would be a good time to get this information? Because you've got to get all this information. You typically are not going to ask them right in the middle of the contraction, so you might have to time your questions in between their contractions to get that information as much as possible. So let's walk through a normal childbirth. Okay, so we've looked and we've decided that we have an imminent delivery. We've got crowning, or they feel the urge to push, or something like that. So the first thing, control your scene. If you're in the middle of the mall parking lot, don't deliver this baby in the middle of the parking lot. Get in your ambulance. If you're in somebody's residence, make sure that you don't have a bunch of people milling around. You want to have help. You want people there. You need somebody, a support person at the mom's head to help her, but control your scene. Control your scene. If you need to get in the ambulance, do it in the ambulance, but control your scene wherever you are. Provide privacy for the mom. All right? Proper PPE is vital. Childbirth is messy. I'm going to be honest. It's kind of gross. All right? I mean, it's a miracle of life, and it's awesome, it's cool, but it's gross, too. There's fluids that splash out. There's blood. There's bodily fluids. There's just stuff. And you have to be kind of close by the nature of it because you've got to catch this baby, which means your face is close to all this bodily fluids and blood and stuff. All right? Your eyes, your nose, your mouth, all mucous membranes. The vagina, mucous membrane. You can have disease transmission through this. Okay? So it's super important. Wear a face shield. At minimum, wear goggles and a face mask. But if you can, wear a full shield. you'll want to put on some kind of gown or something. Most of the time the gowns that they put in the OB kits are woefully inadequate, but it's still better than nothing, because I'm telling you, a lot of stuff comes out during childbirth. Okay, you want to have the proper PPE and be protected as much as possible. All right, you're going to put the mother on the bed, on the floor, on the stretcher. I'm not a super big fan of the floor in and of itself if there's another option, because that means you got to get way down there on the floor too. If you put them on a bed or a couch or a chair, make sure that you've got a little bit of room below the vagina where you're not, if the baby slips or something, it's not going to fall out and hit the floor. We don't want that. All right. So just make sure that you've got an adequate place to prepare to put the mother there. Okay. We're going to remove any clothing, like we said. We already talked about that. We're going to position your assistant and your OB kit. Now, don't get excited or terrified and rip open your OB kit, because then everything goes flying, and now it's not sterile, so we can't use it. We've got to go get the other one to open up. All right. So inside the OB kit, all right, you'll have some gauze sponges. You'll have some basically like a paper blanket to dry the baby when it comes out. You'll have a bulb syringe. You may have some hemostats. You'll have some clamps for the cord. You may have tape. You may have a little hat or something for the baby. You'll have sterile gloves. You'll have an absorbent pad. You'll have a bag with some zip ties, basically, or twisty ties for the placenta. You'll have an OB pad. And you may have some other drapes as well, and so sterile 4x4s. Okay, so you have the drapes. You would drape them over the abdomen like this, and the legs. This is if you have time, okay? And this is just trying to present as sterile filled as possible for the mother. All right, you're going to tuck your absorbent pad. I like to put down some towels and then put the absorbent sterile pad over it here. All right, and this is going to help soak up any of the stuff that comes out. And I'm telling you, there's a lot of stuff that comes out, a lot of fluid, a lot of blood. Up to about 500 milliliters of blood loss is normal during delivery. Okay, and we're going to have the rest of our stuff nearby where we can easily access it, but it's not in the way. Now, with the sterile gloves, we don't want to put the sterile gloves on too early, because then everything we touch, they're no longer sterile outside of the sterile field. We want to reserve those for actual delivery of the child. If the sterile gloves do not fit you, or if you don't have sterile gloves, then just use clean gloves, all right? And minimize what you touch, because the baby, when it comes out, it doesn't have a whole lot of immune system, if any at all. So we really want to make sure that we are protecting and minimizing exposure to any bacteria, viruses, or anything like that for this infant. All right. If you are off duty and somebody needs to go deliver, be very careful. If you don't have the proper PPE, you are likely to expose or be exposed to any number of infectious diseases. All right, just keep that in mind. But you would need some clean sheets and towels, some kind of new shoelaces or heavy twine or something to tie off the cord, a towel, plastic bag, something to put the placenta in, and rubber gloves, eye protection, and something to wrap up the baby once it comes out. All right, so when we are doing a birth, like I said, we don't deliver babies, the mama do. We're there to help. So we're going to have somebody at their head. We're going to put our gloved hand at the vaginal open when the head starts to appear, and we're going to keep it there now. And as it starts to push out, we're encouraging mom to push. We don't want it to just pop out uncontrolled and cause ripping and tearing and all kinds of problems. We don't want to do that, okay? So we're going to keep our hand there. We're going to support it. As that head comes out, we're going to feel around the neck for what's called a nuchal cord. All right, if this nuchal cord exists, it's the umbilical cord is wrapped around their neck. Usually it's loose, and you can just figure out which way it is looped, and you slip it over their head. If it's not, then we'll discuss that coming up shortly, but you would have to clamp and cut the cord then, because as it progresses, it will tighten down if you do not remove it from around their neck. All right. The next thing is going to be the shoulders. Okay, so remember, we got somebody there providing support for the mom. We're monitoring vital signs. We're being alert for vomiting. As it comes out, we are going to assess if the amniotic sac has not broken. Use your finger, just kind of like give it a little pinch, and it'll easily rupture. All right, we've checked around the neck for the umbilical cord, and you can actually see right here where that umbilical cord is kind of pulled up over the shoulder, but it's not around the neck, it doesn't look like. All right. The shoulders typically you're going to kind of have come down, and that top shoulder will come out, and then you'll kind of help up, and the bottom shoulder should come out. After these shoulders have cleared, usually the rest of the baby just kind of slides on out because it's much smaller. All right, so the head and the shoulders are going to be the worst part. And then that's usually 2 to 3 pushes, and then after that, then the rest of it should just kind of slide on out, and you've got your baby there. Okay? We're going to support this baby during the entire process. Now, we will assess the airway, okay? We only suction with the bulb syringe. We do not use any mechanical suction. It is too powerful and will cause what's called barotrauma to this newborn, right? If their airway is compromised, if they are having severe respiratory distress, then we can use the bulb suction to clear their airway, and then we would suction the mouth and then the nose, but only if necessary. We do not do this routinely. Okay, because when you do this, you're also suctioning oxygen out as well. We're going to note the time of birth. All right, that's really important. That's going to go on their birth certificate. So we're going to note what time it is. We are going to keep the baby level with the vagina at first, okay? We're going to grasp the baby. The babies are pretty resilient, okay? They're pretty resilient. Support the head, all right, because they have no muscle tone to keep their head open and their airway open. But we're going to grasp them pretty good and get a good hold on them. They're going to be slippery. They may be, hopefully they'll be kicking and moving around, so you don't want to drop the baby, all right? You're going to lay the baby on its side, all right? We're going to keep it level with the vagina. And the reason we do this is we don't want the blood from the umbilical cord to either leave all drain down into the umbilical cord from the baby, or all drain from the umbilical cord into the baby. We want to make sure that what needs to be there in the baby is there, and what doesn't need to be there is not there. When they're born, they have approximately a Coke can's worth of blood. So that's not a whole lot. So we don't want to increase that too much, and we don't want to decrease it too much. Right? We're going to keep the baby level. We're going to dry and stimulate and wrap the baby as much as we can. Now, they recommend delayed cord clamping by about a minute. So what that means is you're going to dry and stimulate the baby, then you're going to clamp and cut the cord. You want to go out approximately about 10 inches or so, you know, about 2 fists out or so, something like that, and then clamp. And then you're going to go down another fist length, about 3 to 4 inches, and clamp. And then you're going to feel in between those clamps, and we're going to make sure we don't feel any pulsations. If the pulsations are still there, then we need to apply another clamp. It's very thick and fibrous. It's a lot harder to apply that clamp than you would think it would be. All right, but once you've applied the clamps and it's no longer pulsing, they don't have a pulse in that, then you can cut the cord, either with the scalpel or with the shears or anything, you know, whatever sterile equipment that you have that's appropriate to cut it. If you're in doubt, it is better to leave a longer cord than a too short cord, because they can always go back and trim the cord down. That's not a problem. All right. Once we've done this, we've cut the umbilical cord, we're going to wrap up the baby. We'll also get an APGAR score, which we're going to talk about in just a minute. But we're going to assess. We're going to reassess mom. We're going to assess the baby. And hopefully the newborn doesn't need any resuscitation. But if it does, we'll talk about what to do with that. All right, then we're going to prepare for transport. We're not going to wait for the placenta to deliver. We're just going to keep on trucking now that we've got everybody situated. After the baby is wrapped up, you want to do hopefully 1 or 2 things if all is well with mom and baby. And you can either encourage mom to breastfeed as long as she has not had any drugs or anything in her system and hasn't been told not to breastfeed. That will help stimulate oxytocin, which will help the contractions and the uterus to push out the placenta and then contract to slow down the bleeding. And you can also have the baby and mom do skin-to-skin contact, which will help warm the baby, and it will also, to a slightly lesser degree, stimulate the oxytocin result, which is just a hormone that is going to stimulate uterine contractions. It's also the love hormone, the feel-good hormone. So with the neonate, okay, we're going to start assessing as soon as they are born. So we're looking at their breathing, their heart rate, their crying, their movement, and their skin color. All of this is the APGAR score. All right, now the APGAR score in and of itself does not guide the resuscitation, but it gives you an overall idea of how well the baby is doing. And it is based on appearance, pulse, grimace, activity, and respiratory effort. All right. each section is from 0 to 2 points each. So for the appearance, we're looking to see what color are they. If their entire body is very pale or cyanotic, they get no points, 0 points. If their hands and feet, their extremities are blue, but their core is pink, they get 1 point. And if all of their body is pink, they get 2 points. All right. If they have a pulse, if their pulse is over 100, they get 2 points. If their heart rate's under 100, they get 1 point. And if you don't have a pulse, then it's 0 points. For grimace, if they have no reflexive activity to stimulation, they get 0 points. If they have some facial grimace, they get 1 point. And if they start to grimace and cry or sneeze or something like that, then they get 2 points. So basically this is where you like flick the bottom of their foot or something like that. It should irritate them and they should react to it. Basically is what that is. Now, activity. If they are limp and show no extremity movement, that's 0 points. If they show some flexion, but not a lot of active movement, that's 1 point. And if they're actively moving and kicking around, that's 2 points. Once again, that's what we want to see. Respiration. If they have no effort, they get 0 points. If it's slow or irregular breathing with a weak cry, they get 1 point. And if it's good respirations with a strong cry, they get 2 points. All right. So with this, what do we do? So 7 to 10 points, which is most of your babies. They are active and vigorous, and you have just routine care, dry, stimulate, that kind of stuff. 4 to 6 points, moderately depressed, and we provide stimulation and oxygen, and we're going to use blow-by oxygen like you see in this picture here. We're never going to put like a full-blown mask on them unless we are providing ventilations for them. If they have 0 to 3 points, then they are severely depressed, and they're going to need extensive resuscitation care, including oxygen, BVM, and probably CPR. So when they come out with the stimulation, you can rub their back, you can kind of flick the bottoms of their feet. What this is going to do is it's going to irritate them, hopefully, and it will make them start crying, and if they're not breathing already on their own, it will make them breathe on their own and kind of kickstart them and get going. Okay? Their respirations should be pretty strong and have a vigorous cry. Now, not all babies will cry, but they should be breathing adequately and fairly quickly, usually about 40 or so times a minute. Their pulse rate should be greater than 100 per minute. If their pulse rate is less than 100 per minute, we're going to provide BVM ventilations until it improves. And if their heart rate is less than 60, we're actually going to provide ventilations and compressions at a rate of about 120 a minute to improve their situation. All right. Usually, if you have a newborn who has a slower pulse rate, bradycardia for them is less than 100, then the number one cause of that's going to be hypoxia, so lack of proper oxygenation, which is why we treat it early and aggressive. Now, keeping them warm. Heat retention is super important because they cannot regulate their body temperature yet. They can't warm themselves. They can't cool themselves. So we have to do that for them. So we're going to dry the baby first because otherwise evaporation happens and it cools them off. All right, so we're going to dry the baby. We're going to discard any wet blankets. We're going to wrap them up in a dry blanket. If you don't have a proper dry blanket to wrap them up with, you can use one of the space blankets or something of that nature on the ambulance. All right, we're going to make sure to cover their head because they can lose they got big old bobbleheads and they can lose a lot of heat through it. Now, as far as the resuscitation chart, all right, we're going to stay at the EMT level. We're going to stay up here. All right, this is going to be your paramedic level, but we're going to stay up here. Luckily, most of the newborns, they don't need to go past here. Most of them are good at these first two levels. Drying, warming, positioning, suction, and tactile stimulation as needed, and maybe some blow-by oxygen. If that's not cutting it, then we may need to add in some BVMs or maybe even some chest compressions, but very rarely do you actually have to go down here. Usually these two right here will get it just fine. All right. If you do need to do compressions, if that heart rate drops below 100, right, we're going to ventilate at a rate of 40 to 60 a minute, and we're going to begin chest compressions at that rate of 120. So if you have two people, which on the ambulance you should, you're going to do the two thumbs encircling, and you're going to go right here at the nipple line, and you're going to provide your compressions right there. Remember, that's just your basic CPR. All right, heart rate below 100. We're going to ventilate and provide compressions when that heart rate is below 60. Okay? So heart rate between 60 and 80, not improving with ventilation, start your CPR. If it's below 60, go ahead and begin your compressions. Now, aftercare. Caring for the mother. The mother is at a severe risk for bleeding, infections, embolus, the pulmonary embolus, and amniotic fluid embolus. All right, so we want to make sure that we're reassessing. It's easy to kind of forget about mom and focus on the baby, but we got to focus on the mom as well. That's why I say call for another unit. Have some help coming to you. All right, we may deliver the placenta. If you deliver the placenta, just look at it and make sure that you don't see any chunks missing from it or anything like that, because that's going to mean that they're still inside, and it means that there's going to be a harder time to stop the internal bleeding. All right, we're going to control any vaginal bleeding. We are going to provide comfort care and comfort measures. All right, so the placenta itself, the membranes, the umbilical cord, and tissues lining the uterus typically will deliver anywhere up to about 20 minutes after the birth. You typically are not going to want to delay transport going to this. If you can catch it and put it in the bag, then put it in the bag and bring it with you. All right, if it does deliver before you get to the hospital. Typically, they'll start to have contractions again, which will signal that, hey, we're about to deliver the placenta, but they shouldn't be quite as strong as they were initially. Maybe they'll have those labor pains again. Could take a little while to happen. All right, if we don't have, don't wait to deliver the placenta. Now, if you have hemorrhaging, so right after delivery, the top of the fundus, the top of the uterus, should actually be about level with the belly button now. And then it should start to shrink up, and it should be about the size of a softball between the pubis symphysis and the belly button after delivery of the placenta. Now, if you palpate the abdomen, if you deliver the placenta and you palpate the abdomen, it's very squishy, and it's not, you can feel that uterus is not contracting. It's called a boggy uterus. And what happens is it's not going to stop bleeding as much. It's not going to, they're going to continue to hemorrhage, which is a life threat for the mom. So you may have to do what's called a fundal massage. You'll elevate the feet a little bit, and you'll have to actually use your hands to get in there and massage it. It will be painful. Not when I say in there, through the abdomen, like the picture. Okay, you're going to be massaging here. You want to put one hand right here at the bottom of the uterus, right above the pubic symphysis, because you don't want to do a massage and push the uterus out and cause an inverted uterus. Okay, that's a bad problem. We don't want to do that. You only do a fundal massage after the placenta has delivered. You do not do it before the placenta has delivered, because you can cause the placenta to rip away from the wall, which will cause even worse hemorrhage. Okay. Having the baby nurse will actually help with those contractions and will help with the cessation of bleeding as well. All right, so we're going to take vital signs frequently. Be nice, be kind. They're in a world of pain. They've got nothing to dampen all this stuff, and it looks like it hurts something terrible. A damp washcloth to help wipe their hands and face. If you can do so safely, replace any soaked sheets and blankets with dry ones, so they're not having to lay there in cold, wet sheets. That would kind of stink, right? Just as a FYI, there's a good chance that they may have a bowel movement if there's anything in that rectal canal in the colon. As that baby comes out, it may push it out. Throw a towel down and keep on trucking, because the mom, there's so much stuff happening down there that she's not going to be able to tell, and it doesn't do any good to embarrass her by having a reaction to it. It is what it is. All right, so some potential complications. Now, the first one, breech presentation. Now, breech is when anything other than the head presents during birth. Right? They can spontaneously deliver, but they have a super high complication rate and much more high risk for the mom and for the baby. So your general standard rule here is going to be rapid transport. We're never going to try to deliver by pulling on the legs or anything like that. The only one that you might be able to deliver in the field is 2 feet, both legs first. Okay, but we're not going to pull them out. We're going to, if they're delivering, we're going to assist, but we're going to put the mom in head down position with the pelvis elevated. And we're going to insert a gloved finger and form like a V in front of the side of the baby's nose to lift away from the vaginal wall, because when that chest comes out first, the head's still in the birth canal and it's going to try to breathe, and it's got a vaginal wall on its face, so it can't breathe. So you've got to make sure that you address that, okay? Anything other than 2 legs presenting, you absolutely cannot deliver in the field. You know, if you've got 1 leg, you've got an arm, you've got a shoulder, anything like that, we're going to put mom in head down position. We're going to give high flow oxygen, and we're going to have rapid, safe transport to an appropriate facility that can hopefully do OB stuff, that has a delivery center or anything like that, because we can't deliver that in the field. It cannot happen, and it will not happen naturally. Okay. If you have a prolapsed cord, this is a life threat for mom and baby. All right, so this is where you go to visualize, and part of the cord is down through the vagina. So what happens is this baby is going to be resting on this cord, which is going to compress its own blood flow to itself. So it's a life threat for the baby. So we're going to have to try to keep their head away from the cord. So we are going, and we don't want to push the cord back, okay? We do not want to let it dry out. Remember, anything that's on the outside that's supposed to be on the inside, moist, sterile dressing to keep it moist and sterile, okay? But we're going to have mom either lay on her back and elevate the hips, like you can see in this picture, or we are going to have her lay like this, which is the knee-chest position, and that will help take some of the weight off of the baby. I would say that this one's probably a little bit better if you can transport safely like this. And you're going to actually have to take 2 gloved fingers, you know, put your gloved hand, take 2 fingers, insert and pull, insert your fingers into the vagina and pull the vaginal wall off of this cord, because we don't want that cord to be compressed, because that's going to cause problems for the baby, okay? It can cause fetal demise and fetal death. And then we're going to transport to an appropriate facility. Now, multiple births have multiple resources. You're going to need some help, lots of help, okay? First baby delivers, everything else is still the same, but first baby delivers, we're going to clamp and tie the first baby. Then we're going to get ready to do it all over again with the second baby, all right? We're going to take care of the cord, we're going to take care of the placenta. Everything is the same as normal. We're going to keep them both warm and dry, both babies, the mom, all that stuff. Now, with multiple births, depending on whether, you know, on how it actually is in there, mom may have 2 placentas to deliver. Mom may have just 1 placenta. It just varies. We don't have any way to know. So just, hey, placenta comes out, put it in a bag. Another one comes out, put it in a bag too. All right. As far as premature babies, all right, a premature infant is one that weighs less than 5.5 pounds at birth, or who is born before 37 weeks. So what this does is it just increases the chances that there's a complication. All right, we don't want to see this. We want them to be as big and as fully grown as possible, because that's going to give them the best chance that they're breathing, to have less side effects, and have an easier birth. Okay, so if you have a premature baby, we're going to keep them warm. Absolutely. We're going to help keep that airway clear. We may need to provide ventilations or chest compressions as needed. We're going to watch the umbilical cord for any bleeding. We're going to provide blow-by oxygen as needed. And we're going to go ahead and call ahead to the emergency department to let them know what we have, so they can have the appropriate people waiting for us when we get there. All right, for meconium staining. We do not stimulate the infant before suctioning if they have severe meconium staining, all right, because they will then suck in that meconium, which can cause aspiration issues in their lungs. We're going to suction the mouth, then we're going to suction the nose if they have this meconium staining. We're going to maintain the open airway. We're going to provide the ventilations or compressions as needed, and then we're going to treat the baby and the mama. All right? So why do you think it would be important to have another person there watching the mom during childbirth? All right, number one, I mean, support. You're doing a good job, that kind of stuff, holding hands, all that stuff. But also, what if mom, you know, you're down here with the baby, what if mom vomits or something like that? You know, you need to have somebody who, or mom passes out. You need to have somebody who's focused on her to help with her as needed. Now, some antepartum, or ante being before, so pre-delivery emergencies that you may run into. All right, you may have excessive pre-birth bleeding, okay? They may or may not have abdominal pain, but they may be calling just because they are having vaginal bleeding. It is normal for a pregnant woman to have some light spotting or a light amount of discharge, a very small amount of blood during pregnancy, but it should not be an excessive amount, okay? If you have an excessive amount, if you're called out for vaginal bleeding and they're pregnant, assess, or even if they're not, but assess for signs of shock, okay? Those increased heart rate, increased breathing, hypotension, that kind of stuff, which, remember, are some of the signs you see just of pregnancy as well, a little bit. You're going to give them high-flow oxygen. You're going to transport. You're going to place a sanitary napkin, OB pad, over the vagina, ab pad, something like that. And if there has been any tissue that has passed, then save it. Transport it with you to the hospital, whether it's, if it's paper towels, toss it in a sack or something and bring it with you so they can examine it as needed at the hospital. All right. So for a spontaneous abortion, you have the lining, the embryo, anything like that will just spontaneously occur. Now, it can happen for so many different reasons, but it is defined as the delivery of a fetus and placenta before the fetus is viable. Viability usually is considered to start after the 20th week of pregnancy, and approximately 80% of your spontaneous abortions occur before 12 weeks, which is the first 3 months. They usually occur in the first trimester, okay? Spontaneous abortions happens in up to about 20% of all recognized pregnancies. It's usually genetic. It could be caused by uterine abnormality, infections, drugs, maternal disease, or something like that. But, there's a lot of different things that can cause it. All right, patient history is super important when addressing a spontaneous abortion. Ask if they had any uterine cramping, any vaginal bleeding. All right. Some signs and symptoms. Cramp-like lower abdominal pain. They say it's similar to labor. Moderate to severe vaginal bleeding. It may be bright or it may be dark red. And they may have a passage of tissue and clots as well. All right, so treatment for this is going to be supportive care, right? Saving any tissue and supportive care, treated for shock. And that supportive care is going to include emotional support as well on that. All right, so placenta previa. Placenta previa is where the placenta, which is normally, the normal placenta is implanted more up here at the top of the uterus, but occasionally it will actually fix itself across the opening of the cervix, and the problem with that is it's blocking the exit, right? And what happens is as that cervix starts to thin and efface, the placenta is prematurely torn away from the lower portion of the uterine wall, which causes bleeding. Right? There's usually not any pain or abnormal contractions with this bleeding. Your predisposing factors here: more than 2 deliveries, rapid cessation of pregnancy. So like they got pregnant, they delivered. They got pregnant, they delivered. That kind of stuff. Being older than 35, having a history of placenta previa, having a history of vaginal bleeding, and bleeding immediately after intercourse are all predisposing factors for placenta previa. Your assessment, your hallmark sign is 3rd trimester vaginal bleeding that does not hurt. Right? The uterus is typically soft and non-tender on palpation. The bleeding could be dark, could be bright, or somewhere in between, but we're going to assess for shock. We're going to follow the same guidelines for any other antepartum emergency, okay? Shock, treatment, supportive care, transport rapidly to an appropriate facility. All right, abruptoplacenta. So with this, you have these small little arteries in the lining between the placenta and the uterus that are prone to rupture and bleeding. If this happens, this accumulating blood can actually tear and separate the placenta from the uterine wall. This is obviously going to interrupt the exchange between the placenta and the fetus, which causes fetal distress, and it's going to cause severe maternal blood loss. Now, you've got 2 main types of abrupto. You've got a complete, where the placenta completely separates from the uterine wall, and this one, the baby will die unless they are in the hospital and able to get it in time. And a partial, which still has a, approximately a 1/3 to a 1/2 fetal mortality rate. So very, very serious problem here. Some predisposing factors here: hypertension, use of cocaine or other vasoactive drugs, preeclampsia, multipara, which multiple births, A previous abrupto, smoking during pregnancy, having a very short umbilical cord, premature rupture of the amniotic sac, and having diabetes mellitus all increase the odds of having abrupto placenta. Your hallmark sign, all right, is going to be painful bleeding. They'll almost always have a constant abdominal pain. They may also have pain in the lower back. They usually will have uterine contractions, and this blood can be dark red, it could be bright red, but they'll almost always have vaginal bleeding with the pain itself, okay? So we're going to assess for hypovolemic shock. We're going to treat the same. We're treating for shock, oxygen, and immediate rapid transport to an appropriate facility, okay? And remember, this has a very high mortality rate. A ruptured uterus, okay? So as this uterus enlarges during pregnancy, that uterine wall gets very thin, especially around the cervix. And this means you can have a spontaneous or a traumatic rupture of the uterine wall. This means that the baby is no longer in its safe cocoon and it's released into the abdominal cavity. Mortality for the mother is up to between 5 and 20%, and infant mortality is greater than 50% in this. This requires immediate surgery. All right, so what you will see is a history maybe of a previous uterine rupture, a history of abdominal trouble or of trauma, history of a large fetus having more than 2 children before, a history of prolonged or difficult labor, a previous cesarean or uterine surgery, tearing or shearing sensation in the abdomen, constant severe abdominal pain, nausea, signs of shock, vaginal bleeding. You may have a cessation of contractions if they're in labor, and a lot of times the abdomen will become rigid and very board-like, especially in the later stages as they bleed more heavily. All right, so emergency care, treatment for shock. All right, oxygenation, immediate rapid transport, and transport to an appropriate facility. All right. So ectopic pregnancies. In a normal pregnancy, the egg will actually implant here in the uterine wall, in the uterus, okay? And an ectopic, it implants somewhere other than the uterus. It may be in the fallopian tube, which is about 90% of your ectopics, or it could be on the abdominal wall, outside of the uterus, on the ovary, or on the cervix. So a whole bunch of different places it actually could implant. All right, your predisposing factors here: previous ectopic pregnancies, pelvic inflammatory disease, any adhesions from surgery, tubal surgery, anything like that can all cause ectopic pregnancies. Right, usually they'll have a dull aching pain that becomes sharp or knife-like, and that localizes to one side or the other of the lower quadrants here. They may have shoulder pain from blood in the abdominal cavity that irritates the diaphragm. They may or may not have vaginal bleeding. They usually will have lower abdominal pain. They may have a tender, bloated abdomen. They may have some orthostatic vital signs from the bleeding. They may have bruising around their belly button. And depending on how long ago it ruptured, they could have like the urge to defecate or something like that as well. So this is a life threat for mama. So treat for shock. Oxygen as, high flow oxygen, reassess your vitals, rapid transport to an appropriate facility. Preeclampsia and eclampsia. So they don't truly 100% understand exactly what causes the preeclampsia, but basically it is a diseased placenta. Right? The placenta causes problems, and they think that it causes the vessels to spasm, which reduces blood flow, which causes a higher blood pressure. Right? And it will also cause your swelling in the extremities. Now, eclampsia is a more severe form of preeclampsia, which includes seizures or coma. So your assessment typically will find a history of hypertension, all right, and diabetes, kidney disease, liver disease, anything like that. Sudden weight gain, blurred vision, swelling in the hands, face, feet, persistent headache, and a blood pressure elevated greater than 140/90. Okay. If they also have edema and protein in the urine, then they consider it to be preeclampsia, not just the pregnancy-induced hypertension. So treatment: administer oxygen at 15 liters, not in a breather, keep close suction nearby, transport rapidly to appropriate place. If they begin to have seizures, then that is turned into eclampsia, and you need to treat appropriately for seizure management. Provide positive pressure ventilations during the seizure as you can. Transport in calm and quiet manner as possible, and probably go ahead and call for a paramedic intercept because they can give some medications that you cannot to help stop the seizure. Alright, so seizures in pregnancy in general. We're going to look to see, do they have existing preeclampsia? Do they have an elevated blood pressure? Have they had excessive weight gain? Have they had swelling to the face, ankles, hands, and feet? Any altered mental status or headache? And we're going to look hypertension, basically all the other things for the preeclampsia as well. So if they're having a seizure, it is a life threat for the mom and for the fetus. We're going to treat the same as we would any other seizure patient. We're going to protect them from injury. This one we're going to transport on the left side. And the reason for this, any woman in the last trimester, you want to transport on the left side because of this supine hypotension syndrome. What happens is the baby will actually lay on the vena cava, the inferior vena cava, compressing it, which then diminishes the blood flow back to the heart, which decreases your preload in the heart for the mom, which means her blood pressure will drop, and then baby doesn't get adequate oxygenation as well. Okay, a lot of times they'll complain of dizziness or lightheadedness if they're laying flat. They may, in severe cases, experience a decrease in blood pressure, tachycardia, pale, cool, clammy skin, things like that. So assess for your blood loss, make sure it's not shock, but look and see, are they laying flat? All right, they may have that supine hypotensive syndrome. If so, roll them on the left side. All right. If you have trauma in pregnancy, it can be a little bit more difficult to discern a shock because their heart rate's already a little bit faster, you know. They may lose up to 1/3 of their blood before you see any outward signs or symptoms. So you want to make sure you get a good history and ask, have they had any trauma, anything into the abdomen or anything like that that could cause problems, okay? Now, if you have accidental death of a pregnant woman, you have a chance potentially to save that unborn child. So you're going to begin CPR on the mother immediately. Really good CPR, you might have a chance of getting enough circulation to the fetus for it to make it. We're going to continue CPR until they can do an emergency C-section or you're relieved at the emergency department. Okay, this is one of those cases where I might normally, something I might not normally work, like a trauma or something, I would work if I can tell they're pregnant, just to give them any chance at all. You may have to position your hands a little bit higher on the sternum just because of, if they're later in pregnancy. Another thing, the current AHA guidelines as of 2020, right now it's July 2020, they recommend that you do a manual uterine displacement during CPR on a visibly pregnant woman, which basically means somebody's going to be on the left side, and they're going to put their hands on the fundus, on the side of the uterus across the body, and they're going to pull that fundus over and pull the uterus off of the vena cava while they're doing compressions, because you have to have the woman on the back to do compression. So you're basically moving that baby off of the vena cava so that you can try to have the maximum effective CPR there. Alright, now, if you have a stillbirth, it's a very difficult thing to deal with for us and for the mother, for everybody involved. It's, it's a little bit higher emotional thing. If it is obvious that the baby has died before birth, if they have decomposition, things like that, don't resuscitate, alright? If there's any chance of the baby surviving, if they're in cardiac arrest, if they're in respiratory arrest, go ahead and resuscitate them, absolutely. Alright? Go ahead and try. Be prepared for that life support. Be prepared for emotional support for the family as well. Either way, whichever way it goes, be prepared for that. Now, some other things. Embolisms. We touched on this just a little bit earlier, but a pregnant or postpartum patient is a much higher risk for an embolism because of the increased blood volume and because of the increased coagulation properties of the blood. You have a clot that forms in the venous system. It can cause a pulmonary embolism, right? Your shortness of breath, syncope, tachycardia, chest pain, hypotension, paleness, cool, clammy skin, cyanosis, all the same things as a PE, right? Treatment is the same as a normal PE. Maximizing oxygenation, high flow oxygen, positive pressure as needed to supplement ventilations, rapid transport, treat for shock. Causes approximately 20% of all maternal deaths. Okay. Now, gynecological emergencies. Vaginal bleeding in and of itself. whether pregnant or not. We're going to treat it as a potential life threat because we cannot stop vaginal bleeding. We cannot compress that site. It's a non-compressible site. It's considered to be internal bleeding. We're going to check for any associated abdominal pain. We're going to monitor for hypovolemic shock. And then we're going to transport to an appropriate facility. All right. If you have trauma to the external genitalia, observe the mechanism of injury if you can. Look for signs of severe blood loss and or shock. Consider the fact that you may have some additional internal injuries, all right, and treat as appropriate. Ice packs may be appropriate. You may be able to just place an external abdominal pad or something in between the legs to help minimize any bleeding. With this and with the next one, with the sexual assault, it is typically a little bit easier if it's a female's having an issue to have a female do the exam. Same thing for male. If it's a male external genitalia issue, they may feel more comfortable with a male observing it. Now, obviously, if you don't have that option, then you just have to do the best that you can. Always have your witness there. Okay. Now, with your sexual assaults, treat any and all life threats, immediate life threats. Try your best not to disturb any potential evidence. If you must cut or remove clothing, do so where you're not destroying any blood or stains or cuts or tears or anything like that. Don't cut through there. Make sure that you are bagging it appropriately. It should go in a paper bag if at all possible. We're going to try not to wash or rinse anything if at all possible because you could be washing away any potential DNA evidence. All right, we're going to examine the genitalia only if there is severe bleeding present. We're going to discourage them from bathing, from urination, defecation, or cleansing any wounds because, once again, that could rinse away any kind of evidence or anything like that. All right, and then we're going to fulfill any mandated reporting requirements. Sexual assault is considered to be a mandatory reporting in most everywhere that I can think of. All right, and as an EMS provider, you are considered to be a mandatory reporter. So make sure that you, make sure that you report that as needed. All right, so let's review some things to think about. Difference. What's the difference between abrupto placenta and a placenta previa? Remember, abrupto placenta is where the placenta kind of rips away from the uterine wall prematurely, and then a placenta previa is where the placenta grows over the cervix. All right. Abruptos, critical emergency, very painful. Placenta previa, usually a little bit less serious and usually painless, but can have bleeding. Right. How do you care for a prolapsed cord? Right. If you said, tell the mother not to push, put her in knee chest position, lift the body part off of the cord, and cover the cord with a moist sterile dressing and rapid transport, you are correct. Right. And what do you do if the bag of waters, the amniotic fluid sac, is still intact during delivery? Right. You gently pinch it between your fingers and tear the sac and pull it away from the infant's face. What do you do if you have a nuchal cord? You can slide their fingers under the cord, try to wiggle it loose, sliding it over the head. If you can't loosen the cord, then you go ahead and clamp and cut it. All right. You're called to a pregnant woman in labor. During your evaluation, you found that it is their first pregnancy, the baby's head is not crowding, and tractions are 6 units apart. You ask the mother if she feels the need to move her bowels. She says no. So, are we going to prepare for delivery at the scene, or are we going to transport to the hospital? I think in that one, we're probably going to get ready to transport to the hospital, right? But always be prepared to deliver if you need to. If you do need to deliver and you're in the ambulance, pull over to a safe location and do it there. Done.